Thank you, Ritika. Thank you, Dr. Aditi. Thank you, Kumar Prabhash sir, for a kind invitation. I'm Dr. Prahlad. I'm a radiation oncologist in Chennai. So the topic, the paper abstract given to me to present is about salvage radiotherapy. Yeah. So it's about salvage radiotherapy. We know along with salvage radiotherapy, we have to give 6 months of GnRH analogs. Along with that, this paper is studying whether the addition of abiraterone, apalutamide, and prednisolone improves outcomes. The paper was presented by Dr. Guyan, so a well-known radiation oncologist from Dana-Farber Institute. It was presented in ASCO last year. So we know the background that from the Getug paper, we know that RT versus RT plus 6 months of ADT, there's an improvement in progression-free survival with a hazard ratio of 0.54. So the investigators, they proposed that when patients needed salvage radiotherapy, and if they had at least one unfavorable risk factor, and they listed the unfavorable risk factors below, those with Gleason 8 to 10, PSA more than 0.5 when they started the radiation, either nodes were positive, T3, T4 disease, and surgical specimen, PSA doubling time of less than 10 months, negative margins, or a persistent PSA which never dropped, or a local recurrence as seen on imaging. When any of these risk factors were seen, the investigators suggested that whether the addition of 6 months of intense treatment with abiraterone, prednisolone, and apalutamide, seen here. So salvage RT plus 6 months of GnRH analogs plus abiraterone and prednisolone and apalutamide, or just 6 months of ADT and bicarotamide, whether there's an improvement in progression-free survival. That was the primary objective. They also had pre-specified subset analysis of those patients who started their salvage RT when the PSA was less than 0.5 or more than 0.5, which is a pre-specified subset analysis, or for patients who had node-positive disease or node-negative disease in the initial specimen. The doses of the medicines are as standard protocol. The two arms were equally distributed with regards to the important parameters like age at diagnosis, which is in the 60s, which is somewhat similar to our population, our patients. Race was equally distributed among the two arms. Gleason score, again, Gleason 9 was almost 1/3 of the patients had Gleason 9, similar to our patient population. PSA at enrollment and node positivity. So when they studied the entire cohort, there was no significant improvement in progression-free survival. This was the primary endpoint. There was no significant improvement in 3-year progression-free survival when an intense regime of apalutamide, prednisolone, and abiraterone, along with ADT, 6 months ADT, and salvage RT was given. So the benefit was bordering statistical significance, 0.06. The hazard ratio was 0.7. It had to be less than 0.5 to be statistically significant. So there was a benefit of about 8%, which was not significant. Even the metastasis-free survival was a good 90% and 87%, no difference in metastasis-free survival with intense treatment across all the patients who had at least one unfavorable prognostic factor. But as this is the only positive thing that came out of this study, and this is very relevant to us because in our practice we see quite often post-radical prostatectomy, patients delay the salvage radiotherapy, and some of them start salvage RT when the PSA is more than 0.5. In this study, they found that when adding an intense treatment of 6 months of ADT, 6 months of abiraterone, apalutamide, and prednisolone, showed improvement at almost a 20% improvement in 3-year progression-free survival, and an almost 18% improvement in metastasis-free survival with very low hazard ratios and significant p-values. But this was not the case when they in the pre-planned subgroup analysis. Even the PSA was more than 0.5. When the PSA was less than 0.5, there was no improvement. Even in node-positive disease, there was no improvement. So the final conclusion, as presented by the author in ASCO, he said this, that although the primary analysis did not meet the pre-specified threshold for statistical significance, it strongly suggests that addition of abiraterone, prednisolone, apalutamide to salvage radiotherapy and 6 months of ADT may improve progression-free survival and metastasis-free survival. But what has shown improvement is when patients started their salvage radiotherapy after PSA was 0.5, they showed a statistically significant benefit in both progression-free survival and metastasis-free survival. So we are discussing since morning about salvage radiotherapy and whether 6 months no ADT or 6 months ADT and 2 years ADT. So this, and we have come somewhat getting to the point that 2 years ADT is good or is better than 6 months ADT. So in the context when patients start their radiation salvage RT after PSA is more than 0.5 and they would require prolonged ADT, 6 months of intensified ADT with next generation anti-androgens may provide an attractive alternative to lengthening ADT for patients with rising PSA and unfavorable features after radical prostatectomy. So my take on this is that final mature results may show an improvement in all subgroups. It was just bordering the level of significance. It might show improvement in the final results, mature results. But we now have an option of intensified 6 months of treatment for those starting salvage RT when PSA is more than 0.5 rather than the 2 years of ADT. Benefit is almost in the range of 18 to 20% as compared to ADT plus bicalutamide of 6 months. And the side effect profile, which I did not mention earlier, was acceptable in both the arms. Thank you.